I'm going to apologise. I know on your programme it says there's two of us here. My colleague Daniel from West Midlands, who most of you, I hope, will be familiar with, is really, really poorly. So I'm going to present his slides and my slides. So I apologise now if I make a mistake. I probably will, because I haven't practiced his slides yet. However, the Patient Safety Collaboratives are part of NHS Improvement, and there's 15 of us across the UK, all working on the same programme. So these initial sets of slides are slides that we use nationally that we all have to work towards. And like all quality improvement programmes, they're very wordy. But there's several of them. Managing Deterioration is the one that I run for our Eastern region, and the one that Dan also runs for the West Midlands, and which is why we work very well as a team. Within that, we've got Medicine Safety, which is now starting to think about how we do that under the deterioration bubble. Maternity and neonatal, mental health and system safety. And when we talk about system safety, we talk about the new Patient Safety Instant Response Framework, which has been published but actually isn't going to hit primary care and care homes for a while yet, and it's already backed up in the system in acute. So please don't worry about it, but if you hear about it, it's going to change the way we work in the NHS from an incident reporting perspective. It's going to be a big change in the NHS. However, it's not a scary change, it's a good change. It's about learning, and it's about us understanding what's happening on the ground floor. So, quality improvement. I'm a nurse by background, and for me, drawing diagrams with lots of things on it says, actually, I want to make an umbrella and I want to make everything happen under that one heading. What we do with quality improvement is we try and break that down into small scale change. So actually, the bits that we get right are good. The bits we don't get right, we've tested, and then we retest them again when we've made changes. What we like to do, I think, within any caring environment is just fix it. And we want to make it right, and we all want to do the right thing at the right time. However, the work that we're doing within the collaboratives is in a very crowded space. Some of the work that we do, deterioration, doesn't sit on its own in isolation. There is a lot of work we do around prevention, and we use a framework for that. But if you think about falls and frailty, that has a work stream of its own, and yet if we can prevent people falling, actually, we prevent them deteriorating as well. So it becomes a much bigger picture of the things that we want to be working on. And I know Sarah talked this morning around nutrition and hydration. If somebody hasn't got the right nutrition and hydration on board, they will fall. So all of this starts to sit under one big umbrella. So we focus on what works well. We generate conversation, and I can talk forever, but we do generate conversation. But most importantly, we learn that and we share it as far and wide as possible, and that's why we're all here today, to make sure that we're doing that. So factors that become good outcomes, there's this three triangle here. Some of you will be familiar with the Restore 2 training around deterioration. This starts to look at this triangle and how that works in a much bigger patch. So it's about getting the right people to the right place, the right time. It's as simple as that, but it's not that simple, because we live in a very complex world, and we live in a very complex system after different system after different system. So we've got ambulances, we've got acute care, we've got secondary care, we've got community care, we've got care homes, we've got social care, residential care, mental health care. All of those have an expectation that we can fix it. And actually, unless we bring them all together in a system-wide vision, it's really difficult to be able to do that. But to bring them all together in a room, you've got 30 different opinions as well. So actually then, how do we align all of that up? So there's the challenge. On the ground floor, the easy bit is around recognising deterioration, but actually about supporting people to have a voice within there and validate those worries and concerns that people are using. And that's where we use Restore 2, and that's where we use Restore Mini or any other soft science tool. So it might be Is My Resident Well? stop and watch. The essential bit is they're the people that know their resident the best. So we need to understand that at the front end of that as well. And this is the framework we use. So this is the peer framework, and we apply that peer framework to just about any programme. If you think about prevention of harm, harm can be crossing a road. So we put in a crossing, we put in zebra crossings. We can put an intervention in. We can escalate things with dial 999. But if it was a fire, you'd put a fire alarm in and ring a fire brigade. So actually this framework you can apply to so many other things that you're already doing. But by doing that, you align that then with everything else, and people start to generate a common language, the same as we do with SBAR. So our networks this is your Midlands network, and as you can see, that one person, which is the lovely Dan, who's at home poorly, he goes to all of these meetings. I do the same in my region, and I try and cross-pollinate all of those meetings. I'm like a little bee, and I cross-pollinate every single one of them with all of the things that are going on. And that's around that collaborative piece and bringing all of that information together. We've also done some work with the CQC and the new framework that's coming out. So a lot of that learning that we've done since we've been working on this programme has gone up the chain as well as down the chain. So that's nice. We're nicely in the middle. And the national ambition is that we will have 95%, I think what's he got in there? 85. I've got 95% in my region, I have to say, of care homes being able to use or access all of these tools. And that may be digitally, on paper, access training, some of the training portals, some of the apps, you name it, it's all out there. We've just got to give people license to do it. So that's the national picture, and a lot of that is around what's happening not just in the Midlands, but everywhere else in the UK. As part of the patient safety collaboratives, they sit inside the academic health science networks, and they're funded. So the collaboratives are funded by NHS Improvement. The academic health science networks are funded by NHSE and the Office of Life Sciences, which is a bit of a mouthful when you've been doing this all day. And what the academic health science networks do is look at innovation and all the new kids on the block and help those small businesses actually navigate what is a complex system to get anything into the NHS, let alone out again and to point of care. And do it in such a way that it's robust, it's safe, and it's able for everybody to use. And I did some work with some innovators during COVID, mainly because I'm not a techie, but I just wanted to make a difference, and I wanted it to be more than just paper. So one of my pieces of work that I did before was around electronic observations in acute hospitals. I wanted to take some of those principles out and allow people to use that everywhere else, because it made sense to me. The National Early Warning Score is the one validated tool that we've got across all of our systems that all of a sudden stopped at one edge and everybody went, oh no, we do it a bit differently. So when you talk to a tech company, they go, oh, I've got a risk stratification score. That's lovely. But does your ambulance driver know that? No. So let's make sense of this and let's standardise some of this. So why do they exist? As I've said, our focus is on the east of England, but on that one patch, within the east of England, we've got some great seaside places, but we've also got huge gaps between a care home and the people that they need to get to them. So there was one bit there. Our Wi-Fi network, that's challenging. And it's nice when you've got on a day off and you don't want your phone to work, but it's not great when you do want it to work. So we looked at telehealth. Now, a telehealth system is essentially a clinician talking to a person at the other end via a screen. Now, you can make that as simple or as complicated as you want it to be. And in our region, we've done a lot of work, certainly in acute hospitals, around stroke services, identifying those patients early, and getting the right support to them. It also worked around that consultant to consultant conversation where we referred patients to specialist centres. But how can we then make that translate into something around care homes and GPs and community health teams? And it's not new, telehealth. It's been around for a long, long time. It's just that we haven't really taken the opportunity to go, I know, I can do something with it. But then that happened. And that provided a really good opportunity for us to look at how we remotely worked with care homes. I did a pilot with this across our region, and we had 35 homes across the whole of the 7 patches, specifically focusing on those homes with residential care. Those were the homes that normally our clinical support teams would be able to go into, day in, day out. And all of a sudden, everybody was left without a voice and without being able to get help. Some of the work that we did with that was absolutely incredible. We went into homes, or we virtually went into homes. Before then, we went in with pat dogs. They were great, they loved it. But we were able to then work with people in those care homes and start to think about how we can make telehealth work for them from their end and grow this from the ground up. And it's been some of the most amazing work I've ever done, some of the hardest work I've ever done. And some of that was the hardest bits, were getting the infrastructure in. So the Wi-Fi networks, could we find a better kit that didn't lose any data if we are in 4G, 5G, 3G? Because data is really important when it's got patient identifiable data in, their vital signs. We don't want to lose that. That's the bit that we're trying to escalate. And at the time, there was the virtual wards were starting to happen with the COVID oximetry ward. But those wards didn't extend as far as care homes. So I was really keen to make sure that we extended this further. So what we did is we found a piece of equipment that had a backup plan, that we could still print off everything that was on it, but had everything that we had at the front door being able to be printed off at the other door. All of that equipment in there was Bluetooth enabled. It connected with the tablet. It absolutely mirrored the Restore 2 paperwork as well as our soft signs tool, so all of that was on there. It had a nutrition and hydration score on it. It had a falls assessment score on it. It could refer to podiatry services if they could get in the door, which at the time they couldn't. But it can do that now. The other thing that it could do is take secure photographs. So what a lot of people were doing, and there was the only way to do that, was use their own telephones and use their own devices. We wanted to make sure that people were safe and not using their devices, but could also have a good enough quality photograph that could help other teams, so pressure ulcers, tissue viability teams, dentists. You know, a lot of people within that environment at that time, you couldn't get services in. So if people were gradually deteriorating, others were really flourishing, don't get me wrong, but the ones that deteriorating, we couldn't get that support in. But to grow this with the staff in those homes was the key to making this work. So what went from 35 homes has now got 100,000 residents on them. And that wasn't because we did this. It was because people wanted it. And the timing was right, and we allowed people to design this system with us. The impact that it has on primary care, if we use the National Early Warning Score, is that everybody talks that one common language at the other end. So that phone call that we've all talked about over the years, if somebody's not very well, I don't really know what that is and what's happening to them, but I need somebody to come and help me, has turned into, I'm really worried about somebody, I've done a news score and it's 5. And that triggers a response. So that validates those worries and concerns, and that's what's really made this work. We haven't asked people to be that clinical decision maker. That clinical decision maker is on the other end of the remote bit, these people. the secondary care people, the responders, your primary care services, and where we are now starting to grow those 2-hour response teams. These people can get into this system and it connects with System 1, EMIS, whichever one it is that you want to. So interoperability of all these systems is really starting to work. For secondary care, we've never had baseline observations of people coming into hospital. For anybody that's worked in ED, if somebody's coming in with a really slow heart rate, the chances are you're going to treat that. But it might be normal for them, but we'd never know because we didn't know any of this. So actually, we're making a difference and much further down the line as well, and helping people to really live well in the environment they're in. Now, I talked about implementation and the journey that everybody has been on with this, in designing this, and it was a really rocky road. We've had a lot of sleepless nights. We've done a lot around virtual training, and I've done that whilst I've been working somewhere else, but it's about creating those opportune times as well. So nights, weekends, could we do all of this? I'm not saying we've got to do it now because we are post-COVID and we need to move on, but during that time, we seized every possible moment we could to do that training. But it's a culture shift, and we're moving towards another generation. I can't remember who it was. Somebody was talking about generation X, Y, Z today. And what came with me was, actually, I think I've got a bit of that somewhere, but not there, but I've got another bit there. Because actually, I want this to happen. I want us all to be enabled to do things much easier and to have a common conversation. But what we don't always do is embed and sustain things, because some of that is not our fault, it's around the licensing. So what we try to do with this work is provide a business case for people to say, actually, we want to fund the license, but we can't evidence it. So that's what a lot of people say is, it's great, we'll spend all this money, where's your evidence that it's working? And I don't like to say return of investment, I'd rather say value for money. But we sometimes have to talk the right language when we talk about that. This is why we did it. This is the people that were using this. It was incredible, absolutely incredible. What was really hard 3-4 years ago, this wouldn't have happened at all. We'd have had all the doors, not doors closed, but it would have been a real challenge to get it off. But a lot of those boundaries came down while we were trying to do this. The governance, the data sharing agreements, all of these things that actually when we use paper still should be in place. NHS.net, NHS Mail, all of these needed to be in place for care homes to use. But on the back of that, they could have blue light cards. They could access free other training. And all the other things that come as part of the NHS, we're starting to bring care homes in. Equally, we're starting to go out. And we're all starting to change our language to one that is a common, rather than this is the NHS and this is outside the NHS. So, talked about money, because we have to. So £14 million is what we could demonstrate it could save if we scaled this up over 80% of our region. Now, we know we're scaling up to about 80% of their region, and I see this dotted around all over the place now. For those of you that access NHS Futures with your NHS.net email, go onto the care homes forums. There's a lot of conversation going on around there. There's a lot of learning. There's a lot of sharing of documents. Nobody minds poaching. We all steal with pride. So we do a lot of that. Just acknowledge where you got it from. But we connected people within this virtual space. And some of those people are still in touch now. The first thing we did was say, take your mask off and bring a cup of tea. You know, let's start the training when you're ready. But a lot of the people are still in touch now. I put a lovely little car on there because I live miles away from my care homes. And as I said, it's a huge patch to get to. But we saved about 4 trees in just not driving to those areas. And because of that, we could release so much more time for staff. I mean, you're all here today, and it's great that people have released you to come today, but it's a bit of a rare beast now that you get out for a whole day to come to something like this. And virtually, we like to now, I think we'll have a combination of the both soon, where we'll have a lot of virtual things happening, as well as some face-to-face, and it's nice to have that choice. I think people will step back a little bit from technology, but then step forward again back into it. So I think we'll go back, reset, and start again. But the biggest benefit of this was to the people that were involved in this programme. There was some key learning. There's always learning. And we've got to be open and honest. Our most challenging area to get to was primary care. Some of that is because they'd already got virtual ward here, virtual ward there, COVID oximetry here. Can you do blood pressure at home? Can you do something else around diabetes? So there was a lot of other things happening around that space for those people. But once they realised the benefits of it, they started to get involved. It's not there to replace anybody. It's just there to make life better. And we need to remember that when we think about technology in any environment. It can't fix it. We fix it. We're the innovators. We're the people. I've left my email there, and I've left Daniel's there as well, because I'm sure you might have questions, and we'll do a Q&A session in a couple of minutes, but feel free to contact us. The details are all in your programmes as well, because I'm sure there's lots of questions, and I can't cover 3 years in 20 minutes. I wish I could, but I can't. It would have meant I've been very lazy, and we've been really busy.